by Dr. ATHUL PUTHALATH. He is present. Okay, he will be presenting pediatric endogenous endophthalmitis insight and revelation from a therapy care center of tertiary care center from South India.
Good morning, respected judges and my dear colleagues. I'll be presenting on pediatric endogenous endophthalmitis, insights and revelations from a tertiary care center in South India. As we know, incidence of endogenous endophthalmitis varies from 2 to 8%, and pediatric endogenous endophthalmitis has been reported 0.1% in US and 4% in India. The least common cause of endophthalmitis in children is endogenous endophthalmitis. The other type of endophthalmitis are more common, usually seen in premature infants, infections, prolonged hospital admissions, and inborn errors of metabolism. So we did a retrospective study of electronic our EMR records. 21 eyes of 21 children were used at a tertiary hospital during the period of 2014 to 2020. So we included signs and symptoms of any patients presenting with endogenous endophthalmitis, children less than 15 years. We did not include cases which had recent ocular trauma, ocular surgery, or previous recently documented inflammation. The history we collected included febrile illness, recent infection, hospitalization, and we subjected the children to visual acuity, logMAR, or torchlight examination depending on the age of the child, slit lamp evaluation, fundoscopy, and B-scan in which the fundus was not visible. Vitreous tap or vitreous biopsy were collected, and microbiology was done using 10% KOH, gram stain, and culture were done. Positive culture was defined as growth of same organism on 2 or more liquid medium or confluent growth on 1 solid medium. So we also instituted intravitreal antibiotics. PPV was done. Systemic antibiotics were also given. Age, sex, risk factors, time of exposure to risk factors, microbiological profile, treatment details, and final outcome were also documented. So we defined favorable anatomical outcome as attached retina, normal IOP, and clear media. Good functional outcome as BCVA more than 360 and ambulatory vision. Statistical analysis was done, chi-square test for univariate analysis. Descriptive statistics were also defined, and significance was kept at p less than 0.05%. So in the demography, as you can see, male and female were almost close to each other, 57 and 42%, and there was no difference in laterality with 10 and 11. The most common risk factor that we found was fever in 38% of our patients, and there was no risk factor seen in 42%. We do not find any significant risk factors. 1 to 60 days were the time to end off from the inciting factor, and the final follow-up were 3 to 72 months. Microscopic smear examination, 15 patients gave negative report, whereas bacteria was the most common with 8, and fungus were recorded in 2 patients. Streptococcus pneumoniae was documented in 6 patients, which was the most common, and we did not get any growth in 11 patients. So the good functional outcome with a vision of more than 360 was achieved in 33%, while a favorable anatomical outcome was achieved in 71% at a mean follow-up of 3 to 72 months. So this is a sample of our case of a fungal endogenous endophthalmitis aspergillus. You can see the pre-op B-scan, and the corresponding the hyperechoic lesion is seen clinically also in the pre-op fundus image. This was an interesting case, even though not part of the initial data set I presented, which presented to us last month. This is a case of Serratia marcescens with pink hypopyon. This is the intra-op image, and the post-op fundus image with silicon oil in situ. So the mean age of presentation was 6.4 years. Male preponderance were reported elsewhere, but it was equal in our study, male and female. There was no difference in laterality, even though some reports have showed right eye twice likely to be involved because of the direct connection to the carotid. One patient had a history of chicken pox. Even though direct causation is not defined, it could be due to the breakdown of blood-ocular barrier. One patient had dengue fever, which is also a similar case. A single case has been reported by Padmanabhan et al. They have also defined the same as a breakdown of blood-ocular barrier. Streptococcus pneumoniae was the most common in our study with 28.6%. Most articles have published gram-negative as the commonest. So for the first time, we are reporting in pediatric endogenous endophthalmitis, Pantoia agglomerans, usually seen in fruits or vegetations, rare in humans, known to cause a few cases of endogenous endoph, but not in pediatric age group. Burkholderia cepaceae, there is one case has been reported, that too just an endogenous endoph in a 33-year-old male. The child who presented to us also had the history of IV fluids. Alternaria fungus, only one case has been reported in PubMed so far, that too an endogenous endoph, but not in pediatric age group. So 20 out of our 21 patients underwent vitrectomy. So vitrectomy prevents radical procedures like evisceration or progression to panophthalmitis later. So that is why vitrectomy is preferred. Prompt vitrectomy leads to removal of the infective load, endotoxins, exotoxins, and vitreous membranes in the infected eye. 71% in our case had anatomical success, while 33% had improved visual outcome. So case selection in opting for PPV, Maitre et al. Sir, they had published a study in which they selected patients very selectively. So delay in diagnosis, use of inappropriate antibiotics, gram-negative organisms, panophthalmitis can cause poor prognosis. So to conclude, diagnosis of pediatric endogenous endophthalmitis still remains elusive and challenging. We have reported 3 new organisms, and vitrectomy is definitely beneficial, and focus should be on preventing the potential risk factors that cause pediatric endogenous endophthalmitis. Thank you.
Compared the pediatric with the adult population, also taking it from the review of literature, what differences were there in the outcome and what presentation also?
Yes, sir. After this, we had submitted for AIOC. I have recruited 14 more cases. So we have 30 something cases now, which we are writing it up and analyzing. So probably we can use that to compare with the adult population like you suggested.
Your cases.
What form of treatment did you put them on after the vitrectomy in the unusual cases with Burkholderia?
Ma'am, based on the sensitivity, antibiotic sensitivity of the specific organism, as directed by the microbiology department, we started them on IV antibiotics as well as injectables, if the injectable is available in the our armamentarium.
What about steroids?
Ma'am, steroids we did not give.
Okay.